Welcome to AZINT's Guideline Updates. I am Dr. Z, hospitalist attending, and this is KC, our PGY1 resident. Today is episode G3, Sepsis and Septic Shock. Educational only, not individual medical advice.
So we have new sepsis guidelines. Again, March 2026. I have to be honest, Dr. Z, every time someone says new sepsis guidelines, I brace myself. Is this actually going to change anything I do tonight?
Yes, and meaningfully. This is the Surviving Sepsis Campaign 2026, endorsed by 24 professional societies, published in Intensive Care Medicine and Critical Care Medicine. 129 total statements, 46 of them brand new. It is not a minor refresh.
Okay, 46 new statements. Where do we start?
The single biggest change for a hospitalist is the antibiotic timing framework. The old rule was antibiotics within 1 hour for everyone who looks sick. That rule caused its own problems. Unnecessary antibiotics in patients who did not have infection, C. diff, resistant selection. The 2026 guidelines replace that with a 3-tier framework.
Walk me through the 3 tiers.
Tier 1, septic shock. Antibiotics immediately. That part has not changed. Tier 2, probable sepsis without shock or hypotension responding to fluids. Evaluate fast. Start antibiotics if your concern persists, and do it within 3 hours. Tier 3, low suspicion for infection, no shock. You can defer antibiotics and monitor closely. The point is that you're using clinical reasoning, not a blanket timer.
So if a patient comes in with a fever and a slightly elevated white count but looks fine, and I am not sure if this is sepsis or something else, I actually have permission to think for a moment before I hit order?
Exactly. That is a huge shift in framing. The urgency still scales with severity. Shock means now, but possible sepsis in a stable patient means you have a window to think, gather data, get cultures, and then decide. The key is it still has to be rapid and documented.
What about the antibiotics themselves? Anything change there?
2 major upgrades. First, extended infusion of beta-lactam antibiotics is now a strong recommendation. Not conditional anymore. Strong. That means running piperacillin-tazobactam over 4 hours and meropenem over 3 hours instead of a standard 30-minute bolus.
I have seen those extended infusion orders but never really understood the reasoning behind them.
Beta-lactams work by time-dependent killing. You need the drug concentration to stay above the minimum inhibitory concentration for as much of the dosing interval as possible. A short bolus spikes the level and then it drops. A prolonged infusion keeps it in the therapeutic range for much longer. In severe infections with resistant organisms, this difference can be clinically significant. And now the evidence is strong enough for a strong recommendation.
So this is a nursing workflow and pharmacy thing, not just a prescribing thing.
Correct. Order sets need to reflect this. Nurses need to know. And if your hospital does not have extended infusion beta-lactams in the order set, that is a systems change to push for.
What was the second upgrade?
De-escalation. Antimicrobial de-escalation is now a strong recommendation. Discontinue antibiotics that are broader than needed based on culture susceptibility results. The days of continuing broad empiric coverage because the patient seems okay are over as a guideline matter. Culture comes back, narrow it. That is the standard.
And there is also something new about anaerobic coverage?
Yes, this is new and it matters for daily practice. The guideline now says to minimize anti-anaerobic coverage unless there are specific risk factors. Think intra-abdominal source, necrotizing infection, aspiration with clinical concern. Routine anti-anaerobic coverage, meaning adding metronidazole or using piperacillin-tazobactam as your default broad-spectrum agent for every febrile patient, is now explicitly linked to microbiome depletion and secondary infection risk. The guideline calls it out directly.
That is a real shift. I feel like pip-tazo is basically the default answer to anything that looks like it might be an infection.
And that instinct is what this is pushing back on. You need to think about the source. If it is pulmonary, if it is urinary, if it is line-related, you do not need anaerobic coverage as a default. If it is intra-abdominal, or if there's a necrotic source, yes. But reflexive coverage is not justified anymore.
What about the vasopressor stuff? I heard something about MAP targets for older patients.
New conditional recommendation. For patients 65 and older with septic shock, a MAP target of 60 to 65 millimeters of mercury is acceptable. The general adult target of MAP 65 remains a strong recommendation. But for elderly patients, Pushing above that target to reach a higher number may not benefit them and could increase vasopressor side effects. This is conditional and based on low-certainty evidence, so you still use clinical judgment, especially for patients with known severe chronic hypertension who may need higher targets for end-organ perfusion.
Okay, so for my 82-year-old who comes in septic and goes on norepinephrine, I do not have to chase MAP 70 or 75 as hard as I would for a younger patient.
Right? 60 to 65 is the target. And there's also a new recommendation that peripheral vasopressor initiation is acceptable while you are getting central access. You do not have to wait for the central line before starting pressors.
That one is practical. Sometimes the central line takes time and the patient is deteriorating.
Exactly. This is a conditional recommendation based on very low certainty evidence, so you need close monitoring if you go this route, but the guideline supports it. One more new area, post-sepsis continuity. Discharge planning should include psychological and physical rehabilitation for post-sepsis syndrome. Cognitive impairment, fatigue, and functional decline after sepsis are real and often ignored. The 2026 guidelines call this out explicitly.
Let me try to land this. 3 big take-homes from tonight.
Go ahead.
1. The antibiotic timing framework is now 3 tiers based on severity. Shock means now. Probable sepsis means think fast and act within 3 hours. Low suspicion means you can monitor. 2. Extended infusion beta-lactams and active de-escalation are both now strong recommendations. 3. Anaerobic coverage is not a default. It requires a source that justifies it.
That is the episode. If you do nothing else differently after this, learn the 3-tier framework and push for extended infusion beta-lactams in your order sets. Our next episode is G4, community-acquired pneumonia, which connects directly to a lot of what we just talked about on antibiotic stewardship. This is Dr. Z and KC from AZENS. See you there.